thank to Ono the opportunity to be this day with you. I'm in the other side of the country, of the world, so I'm going to talk something very important and the experience that I have to share in this moment with you about the impact of the pelvic floor physiotherapy pre and post surgery. I'm a urogynecologist. I live here in Mexico. I'm the professor of the fellowship here in my hospital that is the most bigger hospital in Mexico that gives attention for security service in women. And also I have a private practice and I have been in this area or pelvic floor about 25 years. So in this moment that I can begin to work together, physiotherapy with surgery, I can share with you that the results are amazing. That when we work in separately here in Mexico, the physiotherapy is beginning, but I think it's a big advance to be here and to share all these things with you. So to begin, we have to review how is the urinary incontinence. You will know that urinary incontinence is definition is as the involuntary leakage of urine, that we have three types of urinary incontinence. That is the stress urinary incontinence, the urge urinary incontinence, and the mix that is the combination of both. Why it's important? Because you know that it's a very, 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 very big impact, significant that affects quality of life, all the women, that it's caused social isolation, decreased physical activity, the women with dysfunction sexual, and all the women have a psychological distress that could be anxiety or depression because of this disease. When we review all the literature to know how are the different options for the stress incontinence and in general the urinary incontinence, we have seen that the first line of treatment is the conservative management. The first line approach that includes a physiotherapy interventions like the pelvic floor muscle training, biofeedback, electrical stimulation, and bladder training are the first approach to all the patients that have urinary incontinence. Then we have the pharmacological management, especially in the patients that have urge incontinence, and we know that we can use two kinds of medications, the antimuscarinic medication that we have to be very careful in patients older than 60 years, and the beta-3 agonist like miraviron, that is one of the medications that we can use also in this kind of urinary incontinence. And then we have the surgical management that, let me tell you, that is, I am a surgeon, so I like very the stress incontinence surgery. I begin doing this with when we make traditional surgeries like birch colpus suspension, and I with the slings. I've been using the sling for more than 25 years. But in this moment, I think that the first approach to a patient is not the surgery because of many complications and because of something that I'm going to tell you later. So we know that physiotherapy is the first line treatment. We have actually evidence-based recommendation. Multiple guidelines and international guidelines says that physiotherapy is the initial approach to all the patients that have urinary incontinence before surgical interventions. For me here in Mexico, it's very difficult sometimes to work to try that the physicians, the urogynecologists, and the urologists understand this, because many of us want to make the surgery as the first time, and we know that that's not the line of the treatment. Then we know that if we have an excellent therapy, we could have an excess of our rate of surgery. And then when we have to balance and we analyze the cost-effective approach, maybe the physiotherapy in the first moment seems to be more cost, but then when we analyze the less of complication, it the risk it reduces a lot of it. You know that all the components of physiotherapeutic for urinary incontinence is could be like the pelvic floor muscle training, the typical stress, the typical training for the muscles that most of us use in our patients. We have then the biofeedback and electrical stimulations, and then also we have to make and try to make a lifestyle advice and educational interventions to try to explain our patients how we have to have avoiding patterns, manage fluid intakes. They have to make an address of an daily of mixtion and a dirty irritants, and also to reduce the weight because also it has a big impact of the in the cure of the urinary incontinence. But when you analyze specifically how the pelvic floor muscle training works, we know that it's very, very important that we have a proper technique. I always say that all the urogynecologists must have to work with a physiotherapist. I know in this moment I say that my first friend is a physiotherapist because we have to work together. We make the diagnosis, and the physiotherapist is the one that have to be in charge of uh, to work with all the muscles of the pelvic floor that are very, very important for all this disease. Also, is that we supervise sessions. We have to, here in Mexico, we utilize different scales to try to evaluate the pelvic floor muscles. We have to make a perfect assessment, and then we have to make a progressive training that it could be gradually increasing intensity, duration, and complexity of the of the exercise. So we have to work out optimal results. When we analyze these kinds of pelvic floor therapy, we have two kinds, the electromyography and biofeedback and the electrical stimulations. The advantage of an electromyography biofeedbacks is that it could provide a real-time visualization of the pelvic floor muscle activity. So the patient could see especially how is their muscles working in the moment that she is making a contractions, and it could be a great feedback of how she's working. And also we have an electrical stimulation that it could help us to have, it could be by vaginal or rectal probes that could have a helping to enhancing proprioception and facilitating muscle activation. Here in Mexico, some patients come with me in the office and tell me how how can they do with their pelvic floor because they want to have a healthy pelvic floor, and sometimes they listen that in this moment there are a different options of treatment. One that is Encela, one that is laser. Patients confuse that laser that is helping to enhance the pelvic floor. So I always try to explain here that the one especially condition that they have to know is that they have to know how their muscles work. In the lifestyle modifications that we have to do in this patient that have urinary incontinence, the first line is to have to have fluid management. I have some patients that come with me and tell me, doctor, I have a lot of missions in the day. I have to go 30 times in the day and maybe 10 times in the night. So when we analyze the intakes of fluid in this patient, we have to see that it corresponds of the number of mixtures that she has in 24 hours. So that one of the recommendations is that she reduce her intake and she has between 1.5 and 2 liters daily, and also try to avoid of the irritants of the bladder that we know that it could be like caffeine, alcohol, carbonated beverage, the artificial sweeteners. And recently, just today, I was reading a paper in the International Journal of Urogynecology that is a review of these irritants in the bladder. And it said that is not an strong evidence to know which one of these one is the most irritant in the bladder, but it's part essentially of the treatment in patients with urinary incontinence. The weight management is important because we know that when the patients have a weight loss, it says that in average of 5 or 10% of their body of weight, they begin to reduce the stress incontinence. So we have to recommend this for the patients, and also a bowel management because it had been identified that chronic constipations increase intra-abdominal pressure, and also it produce or it have to increase the risk of urinary incontinence. So when we have or when we look for a preoperative physiotherapy, it's very important that we can create an optimal foundation, that we must educate to the patient that we have a surgical success when we enhancing a pelvic floor before the procedure. Sometimes we think that also we have to make this after the surgery, but I think that it's very, very important that the patients know that the pelvic floor isn't doesn't is corrected with a surgery for incontinence. I always say you have to rehabilitate your pelvic floor independently that you make a surgery. That both that those things that but you are going to have a great success if you have a physiotherapy of your pelvic floor. Because if you have a strong and well-coordinated pelvic floor muscles, it could be a better support for all the surgical repairs that we make, and not also in urinary incontinence surgery, also in prolapse surgery, and also in the area of urologists in patients that have been with a prostatectomy. It's also very important the rehabilitation of the muscles. So when we give this approach to the patients, it we could be give an valuable tools for postoperative recovery, but we have to try to tell to the patient that these muscles is not to train one day. So we have to keep training all the life. When patients ask me, okay, I make maple, but then what? I said, then is the most important because that's what you do at home to try to keep your muscles trained is the most important. So you have to keep a healthy pelvic floor. When we see this literature review in this publication of Harvis and et al., they found that preparative pelvic floor muscle training significantly improve urinary incontinence frequency symptoms and quality life measures compared to surgery alone. So the benefits were maintained in this follow-up of 6 months. So other patients in another study demonstrated that patients that who initially received the pelvic muscles training and later crossed over the surgery showed comparable outcomes to those initially assigned to surgery. So that's a very important evidence that the preoperative physiotherapy is very, very important for the patients. In this other paper of McLean et al., this landmark randomized controlled trial evaluated the efficacy of adding supervised pelvic floor muscle training to patients that were have a mid-urethral sling surgery for stress urinary incontinence. In this paper, the physiotherapy group received 12 weekly sessions of supervised PFMT beginning at 8 weeks before surgery. And the results were assessed using the validated female lower urinary tract systems and urinary, the part of the urinary incontinence subscale, with the physiotherapy group showing dramatically higher cure rates. It's 70-33 versus 47. And these findings provide an compelling evidence for the incorporating also a preoperative physiotherapy before a sling surgery. So how do we have to make these programs preoperative for the patients? Fair, educational and counseling. We have to explain in an extensive and compressing way to all the patients the anatomy and the functions. I think, and I have been seeing that the physiotherapists, had a lot of models to explain and draws and diagrams. Maybe sometimes the physicians don't work, we don't are very carefully to explain to the patient, but it's very, very important that the patient know how they are their muscles. Second, they have to have a manual assessment and therapy. We have to evaluate the pelvic floor muscles and how they are in the different ways, a progressive exercise program, and then we have to make a functional integration of all this. We also have to know the addressing patient expectations. I think it's very different, the medical patients in America, in Latin America, and in Europe. The system that we have is very different. We have here in America, especially in Mexico, private medicine and public medicine, and sometimes we don't have the same opportunity for all the patients. So we have to know which is the realistic goal setting of the patients that we're treating. So we have to share decision making. As I said, we have to explain the patient the complementary role of physiotherapy before surgery. And then it's very important to have a progress monitoring on how she is working, how she is doing, and how she is getting better of the stretch of their pelvic floor. In the case of mixed urinary incontinence, is very, very important that we know that it's a complex etiology. Stress incontinence sometimes is easier because we have to repair an anatomical a condition that is distressed. We have to make that the pelvic floor it could be stronger. But in the case of mixed urinary incontinence, we have to remember that your incontinence is a complex mechanism of, of well-being of the neural system that could send that all the signs to the bladder to fill and to empty in the right way. So it's very important that we have to search for all the causes of mixed urinary incontinence. Um, it's very, very important that the patient knows that also in this kind of urinary incontinence, the pelvic floor therapy is essentially to have a great successful order treatment. We have to also, in this postoperative physiotherapy, try to restore optimal position. So we have to maintain managing our postoperative complications. Um, Sometimes we have some complication by the surgery of urinary incontinence. Not also the only objective of the physiotherapy is try to rehabilitate the pelvic floor. You know that in this moment we could have pain, we can have voiding dysfunctions, and sometimes we have a pelvic floor hypertonic or hyperactive by the pain secondary to a surgery. So that's the way that also the physiotherapy could be useful in this kind of patients. Also, the one of the benefits is that we can sustain long-term results with the physiotherapy, and also we have to also it helps us to prevent secondary issues. When we have to begin the postoperative physiotherapy, this is the scheme that I use in my office. It could be immediately postoperative from 0 to 2 weeks. Sometimes it depends on the type of surgery. Many times we make a stress urinary incontinence surgery in the same time of a prolapse surgery. So maybe in this moment we need a more time to recovery. But sometimes with an sling surgery, we can begin the postoperative physiotherapy in 2 weeks after the surgery. We have then an early recovery that is this phase between 2 and 6 weeks when we begin to make progressive pelvic floor muscle training. we can begin to increase intensity and healing permits. Also, we can allow to us to introduce bladder training techniques, also in patients that have urgent incontinence. Then is the phase of 6 to 12 weeks, and when we can make integrative functional exercise. And then after 3 months of surgery, we have the maintenance phase that is focused on long-term endurance. That I think all the phases are important, but one of the mains of these phases are the maintenance, because I always say to my patients, you have to learn to work your pelvic floor all the time, because it's like other muscle in the body. If you don't work it, it goes down again. So what is the components of postoperative physiotherapy programs? It makes this including progressive PFMTs. Also, you have to try to work with the scar tissue management. I think all the physiotherapists are expert in this area. Like I said before, you also can have the pain control interventions. And I think that it's very, very important that for optimal outcomes, the physiotherapy works together sometimes with the surgery, but because that's very, very useful to have a great success. What we are working, and especially in other symptoms that are not stress incontinence, especially urgency and frequency, is very, very important that we have to work with the patients in an other techniques to try to diminish their symptoms, the like bladder retrain techniques. This one is makes the one that the patient is increasing in 5 or 10 or 30 minutes in progressive way the time to go to the bathroom. So we say that the patient have to stay, to have a breath control, to try to think in another thing, and she has to go increasing in progressive way the time to go to avoid the bladder. The strategies of your suppressions that are that pelvic floor contraction, rapid such as of pelvic floor contraction that helps her to distraction techniques, and that allows the patient to avoid their urge symptom. And also that we mentioned before, the fluid management and the dietary that is a focus to eliminate the bladder irritants such as caffeine, alcohol, the artificial sweeteners, and the only other one that we mentioned before. Uh, when we make a long-term management, we can see that successful long-term requires ongoing attention to pelvic floor health and function. The most effective approach combines period tune-up sessions with healthcare providers and consistent self-managed practice. So it's very important that we talk with our patients of the importance of this long-term careful. I think that all the women when we begin our visit to our gynecologist, we must be educated about the importance of the health of the pelvic floor and the importance to have a pelvic floor all the time. When we have to pay attention, and when you are making some physiotherapy rehabilitation after a surgery, and you have to send with with your physician, is when, by example, you have some symptom like persistent pain that is below your expected that time. Maybe we have to look for the physician. Is this a major erosion or infection, or sometimes a nerve entrapment by the surgery? And the action is immediately as I have a surgical referral. When some patient has an urinary irritation lasting 2 weeks in the postoperative, in some surgeries, it's relatively normal that sometimes you have urinary retention, but you don't have to extend it more than 2 weeks. So sometimes it's due an overcorrection of the edema of the tissues, or when you had an incorrect slintation. That also you have to refer to a surgical consultation. Um, when you discover or when the patient tells you that have a new set or worsening that your urgency or frequency, it could be due to a detrusor overactivity, maybe an urinary tract infection, or an incorrect sling placement. And also you have to refer to the urology or the urogynecologist. When the patient has a recurrent leakage after initial improvement, you have to think that maybe the sling have a failure, or maybe the anchor, if you are making some old mini slings, have a dysplasia, or maybe sometimes of the tissue, if you're making surgery with native tissue, so it have to have an revolution, a surgical revolution. Or when the patient have unexpected vaginal discharge or bleeding, it could be due to an infection, an erosion, or a tissue, a granulation tissue, a granuloma. So you have to send it immediately to the gynecologist. In the case of the mixed urinary incontinence, that we say that is the one that we have the two types of incontinence, the stress incontinence and the urge incontinence. Uh, it's very important because it has a high prevalence. It says that most of the 40% of women we're going to have in some time of our life a symptom of the urinary low tract dysfunction. So it's very important that we know and we remember, like I said before, that we have a complex mechanism. It's not only the anatomic um, alteration like the urethral hypermeability or our intrinsic sphincter deficit. Sometimes we have something with a neural activity, especially where the detrusor overactivity. Uh, how we can understand better this mixed urinary incontinence? To have a detailed symptom analysis of the patient, we have to try to differentiate between the stress and the urge incontinence. And it's very important we have a bladder diary. Here we use in Mexico a 3-day record to try to understand sometimes the kind of urinary incontinence that the patient know, because when we ask to the patient, which is your main incontinence, they say, I have both, but I don't know especially which is the main or what is the most that happens most of the time. So it's very important to have a bladder diary and also a physical examination to try to look for another pelvic floor dysfunction. We have to know if we also have a kind of prolapse, or maybe how is the scale of perfect in that patient. In some cases, we aim to make urodynamic studies to try to document both stress incontinence and the detrusor overactivity, some especially in the patients that are going to have a surgery. In these patients with mixed urinary incontinence, for optimal management, the treatment approach must address both uh, components in similarly way. Sometimes the patient came with me and I said, doctor, I made a surgery for my incontinence and I'm also in the same way or I'm worse. Okay. Sometimes it happens because we never ask for the patient, which is her expectative, which that the kind of incontinence that she affects more. And sometimes also the only thing that she sees is that she continue using a pump, but she didn't know that the mechanism of action and the treatment is in separate ways. So it's very important when we try to make it in the same way, in simultaneous way. We have two combination therapy, including pelvic floor muscle training, belly training, or suppression strategy, lifestyle modifications, and then when the patient compress that it's a multimodal approach, sometimes it has a better compression of the incontinence she has. Um, this STEAM trial revisited the effects of surgical treatment enhanced with exercise in the type of mixed urinary incontinence was a multi-center randomized trial comparing a midurethral sling surgery alone versus a surgery plus behavioral and pelvic floor therapy for women who have mixed urinary incontinence. In some countries, some physicians prefer to treat in the first time the stress incontinence and then the urge incontinence. I think, like I said before, it's very important to make it in simultaneous way. But what is important in this trial? While they combined groups showing slightly better outcomes of the urinary stress inventory, they use the PURI score. This difference did not reach the predetermined threshold for clinical significance. This suggests that when we add behavioral and pelvic floor intervention postoperative may not substantially enhance outcomes for all women with mixed urinary incontinence. If you remember, we see in the beginning of the slides that for stress incontinence, some of the trials have demonstrated that we have a higher uh, or a superior uh, recovery of the urinary incontinence. But this, in this kind of patients, it's very, very important that we have to say to the patient that maybe the stress incontinence is going to be better, but maybe the urge incontinence, no. We know that is a special population in which the physiotherapy also is useful, is in the patients, in the elderly patients. Um, I think that it's the most important um, group of population in this moment because in all the countries the expectancy of life is going more is growing up. So anytime we begin to have more older patients, and in these patients that have comorbidities, 45 MACE, and also age-related changes, we have to look for the advantage of a physiotherapy to this kind of population. We know that in some patients we didn't make a surgery, but the contraindication sometimes of their comorbidities, or sometimes we just didn't use a medication by their adverse effect. So I think that's a very, very, very important case of the physiotherapy. In women in postpartum, I think that all women that are prepartum and postpartum, they have to have a physiotherapy consultation. And we know the importance when women begins in 6 and 12 weeks postpartum. So try to have an early intervention to try to diminish of the stress incontinence in these patients. So I think that in all the countries, we have to have this multidisciplinary approach because we have to have the physiotherapists. I think that we, like surgeons, couldn't live with a physiotherapist. I think that we have both have a physiotherapist all the time with us. Also, we have a continence nurse. Here in Mexico, there are not a lot of continent nurse, but I think in other countries, that's very important. And also we have to work together with the primary care provider because I think that that's a group of physicians or another care provider that we have to try to educate to try to explain all the patients the impact of the pelvic healthy floor in their all their in all their life. So it's important that when we are making all these recruited of information of the patients. We use the patient-reported outcome measures. I mean, all the validate questionnaire that are in the literature, so we can compare all our results in of the work. So also we can use the objective clinical measures. Sometimes we use here in Mexico modified Oxford scale or the perfect scale. And also I think that it's very important that we have a functional performance metrics. So these are real metrics that could show us how we are working with our patients. Sometimes some barriers, maybe you have in all your countries to this physiotherapy adherence. Desunfortunately, here in Mexico, one of the barriers sometimes are the cost. And I said we have two kinds of medical attention. In sometimes the public patients that go to a secure social security service don't have the access to a physiotherapy. Sometimes the patient they have how to pay it, but they are not constrained with the times. We have to work with this. We also have to sometimes a barrier that is the motivation challenge. Sometimes the patients wait that they could be better in one session. So it's something very important to tell her that they have to work. And in other ways, some of the patients also don't have all the exercise recall that they have to know. It's very important that's a correct expectation setting before any incontinence surgery. We must remember that most of the success of the surgery is approximately 85% for mid-urethral skin. So we have to talk with the patients about this rating of success because sometimes it doesn't mean that the patient has to be complete dryness. So that's the way where the physiotherapy goes because that percent that we have to complete for the 100% is sometimes with the physiotherapist. So we have to also talk with the patient of the possibility that she could have persistent urge symptoms. That we sometimes have to say her that we can work the symptoms in the beginning of the surgery. That also could be a potential complication like breathing dysfunction, like pain, like mesh erosions, in the case of the slings. So it's very important. You like physiotherapy play a key role in these discussions because sometimes you can help us with the surgeons to the patient to understand this important relation because in between these approaches, the surgery and the conservative. I think that maybe we could modify the guidelines of the word and we don't have to say that in first line is only physiotherapy, second surgery. I say it's physiotherapy and second is physiotherapy in the same time with surgery. I don't think that we go have to live before the physiotherapy. It's very important that we make a selection of the patients to make this combined approach so we can um, also work with patients that also could have a prolapse beyond stage 2 of some patients that could have a neurological conditions that could affect their lower urinary tract infections because sometimes in this kind of patients we most need a different approach, but so it's very important to talk about the patient if she is an ideal candidate to make this kind of treatment. We have an integrated care pathway that it could help us to train to all the patients that come with us, making this multidisciplinary treatment that it goes in the first time, the initial assessment, second time, the conservative management trial that we talked before, that's the way where the physiotherapy program that could be biofeedback, electrostimulation, and all the types of physiotherapy is very, very important. Then the surgical planning, if it's indicated. I think that if we make a good physiotherapy, it could be a less of patient that could go to a surgery. And I always says I love surgery, but I think the most of the cases they are not necessary for the surgical intervention. So we have to work with the patients about their symptoms, their anatomical findings, what are the patient preference, patient that want to use a mesh, other one that don't want a mesh, make an abdominal surgery, vaginal surgery, laparoscopical surgery. So we have to talk with the patients. Then we have in five postoperative rehabilitation that is very, very important. And I said before, the long-term maintenance, that is one of the main of the treatments. We have to be a great communication between providers. I think that we have to make a standards communication because it will help us to have a strong evidence on how we are working in this area. I promote and I am agree with this regular case conference. I say thank you again to NovoCare because it's very important that we can share all our experience of all the world, not one, on only one country. And I think that is because of this great communication, we have a progress report and we can have a treatment report of the patients and we can have and very communication to know how to do with all kinds of these patients. When we analyze the cost effectiveness, because really that's very important for everybody, if it's cheaper, it is or more expensive. We say in the first time that it could be that if we go extra for a physiotherapy program for the surgery, it could be more expensive. But when we analyze the or we consider the indirect costs like PAP usage, a lost work opportunity, a reduce of the complications, and a better quality of life impacts, it's better to introduce the physiotherapy program. Some physicians said me here in Mexico, but why would we have to make the patient that she can expend more money extra for the surgery? But we have to have everything in mind. I think there are research gaps and future directions. We have to make optimal preparative protocols because if we review the literature, there are no a lot of information about this. So I think maybe we can begin to work together to make these preparative protocols, and we have to standardize how can we make it better for the patients. Also, we have to make a selection of the patient, a criteria of patient selection. On also, we have to work and focus in that kind of incontinence that is that makes acute incontinence. You also know MAPLE, this revolutionary pelvic floor assessment. I'm going to talk a lot about it, but maybe all of you know more than me. And I have recently 1 or 2 years to know it and to begin to use it with my patients. You know how it could be, it can be introduced in many times before in Dutch. Here in Mexico, we have it like 1 year before. You know how it works with this unipolar electromyography technology and these 24 autonomous electrodes that could help to have a real-time visual interface of how is working the pelvic floor. That is very, very important. So that it helps us to have an assessment phase and data interpretation, a treatment, and a progress monitoring. We know all the advantage of Maple, enhanced biofeedback, and a personalized treatment, and an evidence-based approach that could help us to have a better physiotherapy for the patients. And then when we analyze some of the literature, we know that the results when we use Maples for stress incontinence or incontinence pain, activity restriction, and passive satisfaction is better than in other treatments. Also, we have to have an treatment, initial treatment. We have to have a certification project, the techniques, especially for the patients. But I think that our future directions that could be very important in this kind of patients, especially when you use maple. I want to share with you, just to end, two cases that I have been working with this kind of treatment of preoperative and postoperative physiotherapy. The first case is a 56-year-old female with 3-year history of worsening stress incontinence following menopause. And their symptoms include leakage with coughing, sneezing, and exercise. When we made the physical exam, we revealed a grade 2 pelvic floor strain with the modified Oxford scale and mid-urethral hypermobility. In the preparative preparations, we make 8-week supervised physiotherapy program, including PFT, biofeedback training, and functional integrated exercise. Patient achieved improvement to grade 4 stage with significantly improved endurance and coordination before proceeding the mid-urethral sling. That's the way, that's very important. We have to train before it. Then in the postoperative rehabilitation, we gradual reintroduction this training of PFPT, beginning 3 weeks post surgery. Then we progress to functional integrated in 8 weeks, and in 6 months follow up, the patient reported complete resolution of the stress urinary incontinence. So this is a case that exemplifies the benefits of the integrated approach. And the second case is a patient with complex mixed incontinence. It's a 62-year-old female that has urinary incontinence, predominantly urge. She has 80% of urge and 20% of stress based on symptom assessment. Her history of failed conservative maintenance with anticholinergic and basic home exercise significantly impact of quality of life with social isolation and activity restriction. At the physical examination, we revealed a weak pelvic floor, a grade 1, poor endurance, and inability to isolate pelvic floor contractions, urodynamic activity, and minimal stress incontinence with Valsalva. We make an integrated management approach. The treatment began with intensive physiotherapy with using EMG biofeedback. Then we make her to comprehensive bladder training program and fluid management. After 2 weeks, the urge symptoms improved by 60%. The stress component became more noticeable, and then we make a mid-urethral sling. So that's the way that shows how in the mixed incontinence, we have to treat, in this case, first the urge symptom with physiotherapy, because sometimes if we will make first the surgery, the patient have failed that she have never have any cure rate. We also use some patient education materials to explain the patients how she can work at home, and how can she continue their exercises. And also some patients ask this frequently question that is, how long I will need the physiotherapy all the life? Will I need it to do exercise forever? Yes. Can I exercise during recovery? Of course. When I can resume sexual activity, typically after 4 or 6 weeks after surgery, she can return to sexual activities. We also have to go out to that taboo in pelvic health. I think that it could be a work together if in all the countries to try to create safe space for the patients, normalize them through education, and also make these broader awareness initiatives. I always say, like, if we have a day to try to conscientize of the importance of the cervical cancer or of the another especially issues in the women, we have to make a day for the pelvic floor health women. So I think that maybe we can work together to make this. And then finally, I can say that the summary of evidence of the physiotherapy before and after the surgery shows that we could be a better cure rate of our incontinence, and that in urge incontinence and mixed incontinence is very important that we try to the first symptoms before. the personal, the future directions. I think that it could be focused to an integrated care of all the physicians, physiotherapists, surgeons, the nurse, and all the first care providers to work together for our patients. And I think that uh, all of the our main objectives is to make that patients feel better, and they could be feeling better all the rest of her lives. And leave here my contacts. If you have any doubt, I am very grateful to answer your questions.